The next intervention we're going to talk about is induction. Induction's such a hot topic, right? Like a lot of people talk about induction and a lot of people get induced. And there are medical reasons for induction. Those often include IUGR, which stands for intrauterine growth restriction. That means that the baby is not growing very well because something's going on with the placenta. The other reasons for induction are commonly cholestasis. That's when you have an excess buildup of bile acids and it's wreaking havoc on your liver and causing issues with your pregnancy. The rates of stillbirth go up tremendously with that. And so you're likely going to be delivered early if you have cholestasis. The other things people induce for are preeclampsia, hypertension, gestational diabetes. Those are the most common reasons people get induced. Other reasons people loosely get induced, meaning it's a loose recommendation or a preference of your doctor, would be things like, oh, you have advanced maternal age or a geriatric pregnancy. I highly dislike that term. Advanced maternal age, you might have diet-controlled gestational diabetes, you might have a big baby. Those are reasons that they loosely encourage you to be induced. And then there are some providers that just like to induce everybody at 39 or 40 weeks, depending on their practice, okay? And so understanding the processes of induction is really important. The most important thing about induction is to know what your Bishop score is. Have you heard of a Bishop score yet? So a Bishop score is when your provider or your nurse checks your cervix and they're looking for 5 different things, okay? They're looking for your cervical dilatation. What's your cervix doing? Is it dilated at all? They're looking for the consistency of your cervix. What does it feel like? Is it firm like this? Is it soft or medium like this? Or is it really soft like this part of your finger? They're looking for effacement. A normal cervix that's not dilated or effaced at all is about 4 centimeters thick. So they're looking to see if it's thinned out at all. That's called effacement. The next thing is position of the cervix. When they're checking your cervix, how far back are they going? Is your cervical opening right when they go into your vaginal canal, like right at the end of that canal? Do they have to go a little behind the baby's head, or do they have to go really far behind the baby's head to get to your cervix? And then the last thing is station. Station means how far down in the pelvis is the baby's head. When we look at the pelvis, these are what we call ischial spines. These ischial spines are the landmarks that we use as nurses to determine how far up baby is, okay? If baby's up this high, then baby's like -2, still quite high. If baby's down here across from these ischial spines, then that's a 0 station. And then if baby's down further, that could be a +1, +2 station, okay? So station is where the baby's head is in regards to those ischial spines. So once we get your Bishop score, it will tell us what the best way to induce you is. Now, if you're a first-time mom, it's really important to get to a Bishop score of at least 8 to 10 before they start Pitocin. If this is your second, third, or fourth baby that you're going to deliver vaginally, then having a Bishop score of 6 is completely fine. And the reason these scores are important is because they help us know the likelihood of you having a successful induction with Pitocin, okay? So what are some ways that we can ripen the cervix and get things moving if Pitocin's really not ideal at this point? The first way is called mechanical dilation. We take a Foley catheter and we place it through the opening of the cervix. So you have to be dilated some for us to use this method. And then when it gets in there, we blow it up with a lot of sterile water. Now we want to get it to 40 to 60 mLs of water to help make it nice and big. And then we tape that to your leg. So it gives us a little bit of pressure and it helps your body release prostaglandins so that your cervix can soften and start to dilate. Generally speaking, this will fall out within 12 to 24 hours. And once it falls out, you're usually about 4 centimeters. Now, some people tolerate this really well and they're not bothered by it once they get over that initial discomfort of having it placed. And then there are others that really are very uncomfortable with it. So you just kind of got to see how you're going to do with it. There's also what's called a Cook catheter. And so it's the same idea. We put the catheter in through the opening of the cervix. The difference with this one is we blow a balloon up on this side of the cervix and we blow a balloon up on this side of the cervix. And so if you have balloons of pressure putting pressure on both sides, both the inside and the outside of your cervix, it can help release those prostaglandins a little bit differently. And when this falls out, you'll be about 4 centimeters as well. This is highly used for women who are choosing to do induction for VBAC, meaning a vaginal birth after cesarean. The next way that we help ripen your cervix are called cervical ripening agents. 2 most commonly used ones here in the United States are Cervidil and Cytotec. And Cervidil is something that we insert into the vagina. It's like a cotton thing with prostaglandin gel on it. We place it up inside the vaginal canal next to the cervix. The nice thing about that medication is we can quickly remove it if your uterus gets super stimulated. So the goal of the Cervidil is to help your cervix soften and thin out. The other one is Cytotec. It can be given orally or it can be placed vaginally, and it really just depends on your facility. Now, these are really, really low doses of Cytotec. And the Cytotec can be repeated about every 4 hours or so, as long as you meet the safety parameters of having another dose. Now, it's not uncommon that you get to that 4-hour mark and you're having too many contractions, so we have to give it to you every 6 or 8 hours, depending on what your uterus is doing, all right? There are oftentimes people will come in and they'll get the Cervidil or the Cytotec, and they don't even have to have the Pitocin, because not only do those things help your cervix to soften and ripen, it actually helps you have contractions as well. Now, the risks for both of these medications are that they can hyperstimulate your uterus, meaning you can have too many contractions, or it can make you have really, really long contractions. And so during the time that you have these, you will be monitored for the most part until you get to at least an hour or 2 after the medication has been administered. In some cases, at that point, you can be taken off the monitor for periods of time. Now, the Cytotec can be repeated many times. I think the most I've ever seen somebody have is 6 doses. Now, if you're not doing anything after 6 doses, and you're not there for a medical reason, there's a chance they might actually let you go home and have you come back another day for an induction. So if you've gotten to 6 or 8 on your Bishop score, then they would start Pitocin. Now, Pitocin, the risks that come with that is that you can also hyperstimulate the uterus. And so it has to be managed very carefully and very closely. So nurses will be watching you both in the room and when they're out at the nurse's station. Pitocin usually starts at 2 milliunits. Some hospitals do high dose, which is 4 or 6 milliunits. And then it's increased by 2 milliunits every 30 minutes or so. Now, each hospital varies. It depends on your hospital and your provider and their practice. So there can be variations there. But we're monitoring many things. We're monitoring, how is the baby tolerating the contractions? How often are the contractions coming? Do you have enough of a break in between contractions so that baby doesn't get super stressed out? And how are you tolerating the contractions? Now, there used to be this thinking that with Pitocin, you start Pitocin at 2, you increase by 2 every 30 minutes, and you just keep going. Even if the mom's making progress, you just keep going and going and going. That's not the case anymore. Science has shown us so much over the years. And one of the things that we've learned is that once your body kicks in, there are actually studies that show that we could just stop the Pitocin altogether. It doesn't increase your chances of actually having a longer labor. Your body will kick in on its own and you are good to go. We can stop the Pitocin. The other thing is that sometimes women will need a Pitocin break, meaning they'll need to stop the Pitocin altogether. And I've seen benefits as short as 2 hours of a break, but some of the studies recommend an 8-hour break where they stop the Pitocin. If, for instance, like you've had Pitocin for 12 to 18 hours and things aren't progressing, it's called protracted labor. If things aren't moving along, let's stop the Pitocin. give you a break, let you eat, let you drink, let you take a shower and get a good sleep, and then we'll start again. It clears out all those oxytocin receptor sites. And then when you start the medication again, your body responds much better to that. This actually shows that you could have a decreased rate of a cesarean if you do a Pitocin break. Down below is a link to the study that shows that. ACOG states that women could reasonably be induced at 39 weeks if we consider three different things. The first thing, the values of the patient. Do you want to be induced, basically? Number two, the availability of staff at the place you're going to be delivering. So does the hospital have enough staffing? And number three is, what is the policy in that hospital about failed induction? Like, will they let you go home if it doesn't work? So those are the three things that need to happen as far as ACOG is concerned when it comes to a 39-week elective induction. So your values as a patient are really a part of that. And so I hope you don't feel pressured into getting an induction, and really being able to have a great conversation with your provider talking about these benefits and risks is really important.